innovation in stroke therapy, virtual reality technology. And before I gonna start this thing, let me give a brief up about my presentation today. This is on virtual reality. As you know, the advancement of science has given us a boost for rehabilitating our stroke patients. Even though our traditional methods are still existing over there, like initially the positioning, first the ICU management of the stroke, then the positioning, and then for the rehabilitation protocol, the neurodevelopmental therapy techniques and all. And to assist the recovery of the stroke patients, we have this technology known as virtual reality. And again, I'm thankful that she has already introduced me. I was about to introduce myself over here. And I'm here. And this is my email address. Please, if anybody is having any questions in between or anything, they can directly mail it to me or WhatsApp me on this number. You can jot it down. I'm an Indian. I have done my bachelor's in India and then my master's from US. And I did my fellowship in neurorehabilitation from London Academy and my vibration therapy training from Austria and matrix rhythm therapy from Germany. Currently, I am working as an associate director of academics at London Academy of Sports and Health Science, UK. And also I'm working currently as personal physio to His Highness in Oman. Now going to my topic, the mirror neuron system. To understand mirror neuron system, we need to first see the location of these mirror neurons in our brain. The mirror neurons are placed in the ventral premotor cortex, then inferior frontal, then superior temporal gyrus, and inferior parietal lobes. These are the locations of mirror neurons. What actually these mirror neurons do? As you know, that when we are executing some action, for example, I'm holding a mobile phone. When I'm holding a mobile phone, both my motor and premotor cortex gets activated. Okay. Now, if I'm seeing, suppose my friend Rajesh is taking this mobile and I'm observing him. When I'm observing Dr. Rajesh taking the mobile phone in his hand, again, my motor and premotor cortex gets activated. So when I'm executing an action, the cortex, premotor and motor cortex gets activated. When I am observing somebody doing the action, again, similarly, but on observation also, the motor and premotor cortex gets activated. And suppose if I am sitting down idly and I'm imagining that I am taking the mobile phone in my hand, again, motor and premotor cortex gets activated. So there are three things now. One is action execution, when I am doing the movement by myself. Another one is action observation, when I am seeing anybody doing the same action. And motor imagery, when I'm imagining the things that I'm doing. In three of these situations, the motor and premotor cortex gets activated. And this system is known as mirror neuron system. And this gave rise to virtual reality and different programs. And even, in fact, if you want to design the exercise therapy or exercise protocol for a stroke rehabilitation, for a stroke patient, you need to keep these things in mind. When stroke, for a normal individual, action execution, action observation, and motor imagery is very much possible. But in case when stroke happens, the action execution is gone. He cannot execute an action because of paralysis or paralytic limb. But he has the two abilities still left behind: observation and motor imagery. Another example I have given over here is like inferior frontal gyrus. I understand that you want to take a sip of coffee. Then inferior parietal lobe. I imagine how I would make the same moment. And posterior temporal sulcus. I see you reaching for the cup. So these three things, when combined together, form the mirror neuron system. Virtual reality, the virtual reality games was developed as a tool to complement classical rehabilitation techniques for stroke sufferers. As you know, usually, initially what we were doing, we were taking care of a limb separately, like we want to do the action, if we want to gain the moments in the upper limb, we used to give the passive moments, then the weight bearing, but everything is now changed. You need to consider body as a whole. Don't take the body as a segment wise, because everything is connected within our body. Cells are connected to the tissue, tissue to the organ, organ to the organ system. So when you want to evaluate a stroke patient, evaluate him as a whole, not individual parts. Okay. Then you can consider, if you are evaluating first, observing and assessing the patient as a whole, then simultaneously you have to assess his each part. But initially you have to assess him as a whole. You have to consider body as a whole. Then to boost up the activities, we use this virtual reality program, which is assessing and boosting the recovery in the stroke patients by activating these mirror neuron systems. For you, this is a virtual glass, okay? Usually what we do, we place the virtual glass over the head, okay, of the patient. First of all, before placing it on the head, you need to take a detailed assessment and write down the short-term and the long-term goals, and what exactly you want outcome from virtual reality or your exercise therapy protocol. And after wearing these virtual glasses, you have to program. There are a lot of programs available. You can buy also, and you can also get it online for the purpose. Like if you want to do the movement of the hand, you can, without performing, only the sensors will detect that you are slightly moving the hands. So you can activate your observation and you can activate your imagination, which in turn leads to the regeneration of the pathways which are lost. Here are a few videos. I am hopeful that I will be able to show it to you, and it will be audible as well. And please let me know if it is audible. Is it audible?
Yes, sir.
Audible?
No, sir. No, sir.
Is it audible? Audible?
No, no, sir.
Yes, sir. Hello. Yes, sir, you are audible.
You're watching that even though the patient is not able to do something, but checking It's also giving you the biofeedback.
Please continue, sir. You was audible. Hello. Please continue, sir.
Yeah. I'm just checking.
Okay.
So this is how they are doing the research on virtual reality for the patients. They are developing some techniques for hand rehabilitation protocol. Check out how they are using the hands and how virtually they are doing. Even limited movements in flaccid state also. It helps a lot to boost and stimulate your musculature. So I'm stopping over here. I want to explain. It is also serving the goal-oriented program. Actually, that's why I told you initially, you need to first and foremost make goals, short-term, long-term goals. And accordingly, you have to perform the moments. And I further on continue this. So this was regarding the upcoming program on virtual reality. Going back to the presentation, so you can see the presentation over there. So the task-oriented games are very much important. It's not only your upper limb or lower limb you are going to rehabilitate, but in virtual reality, what you can do, you can even improve the balance and gait. How? Now some motorized treadmills with virtual screens. Am I audible and the everything is audible? And is this
Yes, sir.
slide
Yes,
or
sir.
visible?
Yes, sir.
Okay,
Visible
going
and
on.
audible both are.
Okay, thank you very much. So the virtual reality games are task-oriented games. So whatever task you are giving to the patient, he tries to accomplish that task. And the picture which is on your screen is of a motorized treadmill with a virtual uh, front path. It seems to him that he is walking in a path in a forest. So we create like that environment. And when he walks, it seems to him that he is walking on the straight path. So that's why it also corrects the posture. It also makes you a little bit balanced and also makes you to move your body in according to the task which is given to him. Suppose you have kept 1 kilometer walking for him on the treadmill or 500 meters with respect to the virtual scene which he is seeing. So there is a spot over there where he has to stop and then return back. Then tomorrow the spot may go further on. So he has to perform the action according to the task given to him. So patient is able to observe and get a biofeedback of his action perfection. So he will try to personify and perfect, bring his action in a perfect way. The VR games are believed, believed to activate mirror neurons, as I discussed earlier, or neurons that fire when a person sees a certain movement being performed. Engaged, the mirror neuron system facilitates in the formation of new brain connections and aids recovery. The formation of new brain connections, we also term it as neuroplasticity. Means neuroplasticity starts from our birth and goes till we are on this planet and when we leave this earth. The this neuroplasticity never stops. The new connections are formed every time. Suppose a person meets with an accident and suppose he meets with a stroke. What happens? That part of the brain stops working, functioning, but the other part of the brain takes the same action and starts generating new pathways. So it is a never-ending process. As to summarize it, neuroplasticity is defined as brain's ability to reorganize itself by forming new neuronal and synaptic interconnections which are damaged because of some problem in the brain, suppose stroke or hemorrhage or any sort of brain infection or like that, and thereby develop and adapt to new functions and roles as a result of the effect of learning and experiencing throughout the life. So the brain never stops learning. So it starts up. That's why we are giving repetitive moments in motor re-education or motor training. Why? So that the brain will understand the action which it has to perform. That's why the protocol which you are going to form should be task oriented. Another sort of the gaming which is used nowadays, which has been used for quite a long time, it's known as Wii games. Wii games are sensor-oriented games. Wii has proven to be very popular within the rehabilitation. It is very flexible, forgiving with regards to the moments, and that are needed to play the game, offering the opportunity for a patient to work an affected upper limb with reasonable success, depending upon the severity of hemiplegia, benefiting from the visual feedback that the console and counselors offer. I'm going to give you an example of this. For example, I'm taking an example of a Wii game like playing badminton. The virtual screen is kept in front of a patient and he's giving a sensor-oriented probe, okay? Even though the limited, suppose he's only having a slight grip, not the perfect grip. So this hand is affected, so it is kept in his hand. And whenever he tries to move, even a little bit, the badminton on the screen shows a little bit of movement. So when he sees that he's performing a small movement, so he tries to gain some further on movement on it so that he can throw the shuttle to the opposite person. So he is in actual playing with the computer. The sensors are helping it. So he's boosting, he's encouraging himself to perform the action. And by that, he is also observing that he is performing and he is also slightly executing the action. And he's in the mind, he's also trying to imagine that he is throwing the shuttlecock to the opposite side. That means both the three of the mirror neuron systems like action observation, action execution, action observation, and motor imagery. They both are forming the loop and he's getting rehabilitated thoroughly. The results of the virtual reality in stroke patients. there are a lot of studies going on. So far, the study shows a good improvement in chronic stroke patients. With respect to the acute and subacute cases, there is not much recovery. However, research is still going on in that case. Why this is happening? Because in the chronic stroke patients, what happens? The muscle tone is increased. And how this muscle tone gets increased in chronic and in the acute and subacute cases, it is not hypertonia, it is hypotonia. Why it is so? Because, see, when we talk about the reflex arc, if we take an example of, if you give me a little bit of time, I'm going to share a screen. I will draw a example very quickly to make you understand why in acute and subacute stages we are not able to perform action quickly, while we are not able to get a result in virtual reality, rather than in chronic cases. So I'm sharing the board with you. Quickly I will draw. Bear it with me for my drawing because I'm not good in drawing. Still I will try to make it. See, I'm drawing the transition of spinal cord, section of spinal cord, sorry. Then see, from the muscle cell, from the muscle spindle, the afferent sensory neuron goes via the dorsal root ganglion and crosses the posterior horn and goes into the ventral horn, dorsal horn, sorry. And from the dorsal horn, it goes to the ventral horn. And from here, another neuron gets connected and sends the signal to the muscle spindle, and it gives muscle a twitch. So sensory, just a second, 1 second. I need to cover up 1 minute, 1 minute. 1 second. I'm extremely sorry for a little bit delay. Just a second, I'm going to explain to you. So what happens? This from muscle spindle, I'm talking about the monosynaptic reflex I'm talking about. The sensory neuron collects information from the muscle spindle and goes into the dorsal root and into the ventral horn of the spinal cord, okay? And from it synapses here with the motor neuron and sends axon to via the spinal nerve to the muscle of interest and gives muscle twitch. So this is low motor neuron I'm talking about. And this twitch happens because of the coordination between the sensory motor neuron and the motor neuron. And then there is twitch in the muscle. So what happens during the stroke? And there is also one more pathway. I'm going to show you 1 minute. In the green, this is corticospinal neuron, which comes from the cortex and directly goes into the ventral horn of the spinal cord. And here it helps in the excitation of the lower motor neuron, and it helps in the voluntary movement of this muscle, okay? And there is another one, we call it, 1 minute. I need to check the color. Okay, pink. So there is one more influence which is coming from the cortex directly into the ventral horn, we call it inhibitory influences. So when the stroke happens, what happens to this? This is disrupted. This connection is disrupted. Both the inhibitory influence and the hello, anybody? Is it audible to everybody?
Yes, sir.
Yes. When this gets inhibited, when the stroke happens, these two connections, the corticospinal neurons and the inhibitory influences gets disrupted, and it results in here as spinal shock. And because of this spinal shock, the action potential or the signals to the muscle diminishes, and which leads to the flaccid state in acute and subacute, in acute stages. There is flaccidity because the spine is in shock and there is diminished action potential. And what happens? Eventually there is the rushing of action potential, potential to the muscle, which in turn gives muscle a hypertonic reflex. This is because the inhibitory pathway, inhibitory influences are disrupted because of stroke, and that's why there is high beam of motor neurons, these action potentials going to the muscle, which leads to the increase in the tonicity of the muscle, and which leads to the synergy pattern of the muscles. Once again. Okay, I hope this is clear to you. And that's why in chronic stages, when the muscle is having the hypertonicity, we can use that tonicity along with the other protocols, other neurorehabilitation protocols. We can use them for virtual reality program. That's why initially when the patient is not able to move because of the flaccidity, he is not able to move. That's why the result is still, the research is still going on, but the result is not so good in as compared to the chronic stroke patients. Conclusion. As a physio, we should adhere that for us, activation is priority, which can be further beautified by passivation. Activation means the exercise therapy protocol which you are designing for a patient. And the passivation is some modality which are you adding to the rehabilitation protocol. This means that our activation, our hands are first and foremost, which are in contact with the patient. And passivation is the gadgets which you are using for the patients. I thank you very much. And I hope everything is clear to you. And any questions, please go ahead.
Thank you so much, sir.